Suresh.
The next talk is by Dr. Suresh Ramasubban, who is the head of the department and senior consultant at Apollo Gleneagles, Kolkata. He's going to talk about ICU infection outbreak, mission control. Over to you, sir.
Thank you very much. All right, this talk is meant for people who are going to go on TV. So all the cardiologists, the gastroenterologists and others who make themselves present on TV as the epidemiologist of the country, this is meant for them. For us, I don't know how much information I can get to you guys. I'm not going to use COVID as an example here. So if you think that I'm going to use COVID as an example to how to do an outbreak control, then you're wrong. So you can switch off your mind if you want. But I'll use that. So the idea is obviously I'm not the first disclaimer is I have no expertise in this subject. I am not an epidemiologist. I'm not an infectious disease specialist. I am just unfortunately thrust into the being an ICU doctor. So sometimes we are asked to do these things, and that's why it is. So let's start with basic quiz for understanding how much we know about epidemiology. All right, so anyone can volunteer. All right, so if you get 22 cases of Legionellosis occurring within 3 weeks among residents of a particular neighborhood, what would you call it? Sporadic. All right, don't go on TV. So that's your first, you cannot, Star TV or NDTV is not going to approach you, whoever said that. All right, next one, let's MCQ, you can always go down and then come back upwards. Second one is average annual incidence was 364 cases of pulmonary tuberculosis in one area compared with a normal average of 134 cases per 100,000 population. Endemic. All right. You also should not go onto TV. So I'm eliminating most of the people who can go onto national television. So you're going to be left with only a few people to go on television, and that will be cardiologists and gastroenterologists. Now you know why we are not on TV, except Rahul Pandit. Where is he? So now you understand why we are not on TV. Don't blame the fact that why is a gastroenterologist speaking on the television. Now you know. So they know about these things, I believe. All right, third one. Over 20 million people worldwide died from COVID in 2020 and 21. Pandemic. This everybody knows. So you all are now can go on television. All right, single case of histoplasmosis was diagnosed in a community. Sporadic. Now you got it right. About 60 cases of gonorrhea are usually reported in this region per week, slightly less than the national average. This is endemic. And tuberculosis is hyper-endemic because your rates are much more than the national this thing. And obviously whatever left is the epidemic disease, this thing. All right, so this is the answer, ECDAB. All right, so this is a basic primer of how you approach epidemiology of outbreaks. So if you don't know this and how, because if you cannot define what is, the talk is about outbreaks. So outbreak is nothing but an epidemic. So right now we're in an pandemic, so we can call it epidemic. So epidemic refers to a sudden increase in the number of cases that you see, and that can be, which is normally expected in the population. So I don't call Acinetobacter as an epidemic in your unit because it's endemic. So you might get, occasionally you might get a lot more cases. So let's like tuberculosis. Oh, normally I have 20 out of my 50 ventilated patients with Acinetobacter. Now I have 24. Sure, it's hyperendemicity. And the remaining 18 are obviously Klebsiella. So that is how we work with our world of infection. So that's how, so we're not going to concentrate on that. So what to approach an epidemic, you're going to look at a disease which doesn't occur in the number of cases above what is normally expected. So there you go, you run a neuro ICU, Dr. Subba Reddy. So you have an open plan neuro ICU, and this is, you've got 7 cases of Candida auris infection in the last 3 months. And you as the director of neuro ICU, you're going to be asked, what would you do, isn't it? That's our role. So what would you do? Shut down the unit, go to another place, just clean it with, what is a formalin and just run down water. What will you do? So that's exactly the topic. The topic is I am trying to suggest, obviously I'm not an expert, so you should ideally call an epidemic, somebody who knows how to do it and somebody who's got a training in epidemiology, somebody who's an infectious disease specialist to run this problem, but let us do what we can do with our limited knowledge. So there are certain stepwise approach, we'll talk about it. The number one is obviously prepare for the infection. So when you hear about Candida auris, so first thing that you do is go back, open your books and read about Candida auris. So what do you want to read about Candida auris? What kind of fungus it is? Does it spread? How does it spread? What's the mode of transmission? how does it, is it causing any harm, or is it a good fungus or a bad fungus? What do you tell the family? So on and so forth. So first 1 week is what is called as preparation. You go open your books and come back, and then we will talk about the second problem. So the step one is obviously preparation for the investigation, and that means, so is there any specific symptoms that I can identify early? And you realize Candida auris is not going to do any specific symptoms. It will have the same signs and symptoms as any other candidemia. So it will be the same as Candida tropicalis, it will be the same as Candida glabrata. There is no specific sign and symptom which will tell you that this is. Like even in COVID, we know that reverse et al. Sign and a peripheral GGO on a CT, you can isolate patients when you look at the CT even before the RT-PCR is pending. So that tells us much easier. But here you don't have any specific sign which is going to do that. Then you say, okay, what is the most important as an epidemiology would be, how is this going to be transmitted? So you got to understand that, yes, the commonest cause of Candida in the glass bottle era was the glass bottle with glucose solution. In those days, you will get the Malassezia furfur and all those other all the other fungus when you have a glass bottle which is kept in the heat of 45 degrees outside, and then you run an infusion, you will get all these things. But most of the common thing now would be that Candida is an endogenous flora. That means it has colonized my skin, it has colonized my genitourinary tract and my gastrointestinal tract, and somehow it enters from there. So you have three main routes for it to get through. The most common would be through the GI tract mucosal barrier. That's why the neutropenics get the maximum amount of Candida, because their mouth is, they got mucositis and they got the whole enterocolitis and things like that, and you can get it across. Via IV catheter is what in the ICU we see the most, because our central line related candidemia would be the #1 cause of this thing. And even a peripheral IV would be a source for peripheral this thing. And very rarely you can have a localized focus of infection like a spleen or a kidney, which can be the source. So this is the basic preparation that we need to do before we can tackle the question of how to talk to this. Then is obviously verify the diagnosis. Is your microbiologist right in calling it Candida auris and all the other things that we need to do? And you send it to PGI Chandigarh, to Dr. Arunalok Chakravarti, verify that this is Candida auris, make sure that this is all right, and then you say, okay, yes, he has verified it, that's truly Candida auris, and we really need to do anything that is concerned. So 7 cases in 3 months in a neuro ICU in Apollo Hyderabad should get everybody's bells ringing and say, no, this is a problem, and this is an epidemic, and this is an outbreak, and we need to investigate it. Step 1 and 2 are very simple. Step 1 is arming ourselves with knowledge. Step 2 is verifying it. Then we need to define it. If you're going to fight it, we're going to define what is a case. Because you have to understand that even a colonization with Candida auris in a neuro ICU patient is going to be bad, because 20 days from now, near his tracheostomy and from his central line, he might get a Candida auris back to septicemia and die. So we need to be sure what we are defining. So the case patient should be defined as anybody who has been admitted to the neuro ICU before Candida auris or colonization or infection. That means you're going to screen them, and then you're going to isolate and find out if they're going to be. And the controls are going to be those who never, though they stayed in the neuro ICU, never got colonized with Candida auris. So this is what we're going to do, is to define the case. And this is very important. Say if you're going to define typhoid, if you're going to define hepatitis A when you're an epidemiologist and working with a salmonella outbreak in your FNB department or things like that, to define who's a case, define who's a control, and so on and so forth. Once you do that, then you go into what is called as descriptive epidemiology. Descriptive epidemiology basically means that you describe the person, place, and time. So in this case, the place is very easy. This was the neuro ICU. So this outbreak happened in the neuro ICU. It didn't happen in the medical ICU, it didn't happen in the surgical ICU, it didn't happen in the gastro ICU or wherever it is. So you have a specific this thing. You can have a particular salmonella outbreak after eating at this restaurant on the 2nd floor of this hotel. So then you know that this is this hotel, don't come for next 3 months, you'll get typhoid in this hospital. So you have that understanding. So place is very important in descriptive epidemiology. You describe the person. Does he take risks? Does he have risk-taking behavior? Does he try sushi with whatever, say live crustaceans or whatever he wants to try, and he gets some Vibrio vulnificius or some crap like that. So you can have a person to be well investigated, but more importantly, it is the time frame that is important, because then you get these kind of things. The last one on top here is the classical Legionnaire's disease, which you will get, where you have a single in this air conditioner, there's Legionella, and one by one we go back to Calcutta, Mumbai, Delhi, and one of us will start dropping dead. You know this hotel is to be blamed, and this air conditioning duct is to be blamed for that. So when you go back, remember that that is a possibility. Second would be the standard continuous source epidemic, but more commonly we see is the propagated epidemic, which is what happens in cases of COVID, which is what is happening in case of measles, which is what will happen in case of this example that I'm giving you of Candida auris, that there is some focus somewhere. It comes down and then 7 cases in 3 months. It's not that every day there is a case. So this time and involvement is very important in quantitative epidemiology to understand what's happening. Then you obviously, once you have the time, place and person involved, you develop a hypothesis. You got to blame somebody. You can't say, khub kharab, as in Bengali they say, khub kharab ache. Everything is bad, so nothing can work here. So something has to be said and pinpointed and say, what is the cause of this Candida auris? So who do you want to blame? The neurosurgeon? The neurosurgeon will blame the intensivist. So we are responsible for all the ills that happen in the world. So if then we blame who? Our nurses, poor girls. So the nurses, who do they blame? The ward boys. The ward boys, who do they blame? And the cycle goes down till nobody is actually responsible for anything in our world. But so we need to generate a hypothesis as to what is possibly cause of this, and that depends on our understanding, as I said. So our hypothesis would be, because of the descriptive epidemiology, that this happened in neuro ICU, there is something physically wrong in the neuro ICU. So is it, and if you know that it is not one neurosurgeon, if you know that it's not one nurse, if you not know there is only one subset of patients with, say, subarachnoid following a clipping of some way clipping, then you know this is a problem with the department, with the physical structure of that place. So then you sample the environment. So your hypothesis in this situation has to be based on 3 things that you need to highlight. Is there a difference? Is there any similarity, or is there any correlation? So as I said, in this situation, since the location differs in these 2 diseases, there was no Candida auris anywhere else. So this Candida auris is obviously going to be a neuro. So here there is a difference. So therefore it is easy to generate a hypothesis saying that there is a difference, and we need to focus on the neuro ICU's environment to cause of this. So as I said, the hypothesis would be, when I start this investigation, is that there is a factor which is responsible for Candida auris infection in the neuro ICU. And that's a simple hypothesis to start off, and that there is a factor in the sense there is an environmental factor, because it doesn't seem to be a people, person or a place problem. Maybe one particular, as the classical investigation of the outbreak that Arunalok Chakravarti sir described 20 years ago was with a neonatal ICU outbreak of a single fungus from the hand of one single resident. And that's how they found out that, because that is a common resident who was responsible for an epidemiological outbreak of fungus in the neonatal ICU. So that's what you have to do. And then you can have a cohort type study or a case control study. In a neuro ICU, as this patient, now what I'm going to do is, I have a hypothesis that the problem is in the ICU. I'm going to swab them as they come in, and I'm going to swab everyone every week, or twice a week or thrice a week, and I'm going to swab the environment, I'm going to swab the blood pressure equipment, I'm going to swab the pulse oximeter, I'm going to swab everything, and I'm going to look at what's going to happen in this situation. So, and I'm going to look at the people who got infected or colonized versus those who stayed in the neuro ICU but never got colonized, and find out what's the difference, and I'm going to go back. So this is going to be a case control study that I'm going to be doing in this situation. So doing a case control study to evaluate the hypothesis. So what I would do is that they would screen an admission to the neuro ICU thrice weekly and on discharge. Screening involves culture of swab specimen from the nose, axilla, groin, tracheostomy and wounds, as well as urine culture. Isolates are going to be isolated using MALDI-TOF, and antibiotic susceptibility testing was done on those things to identify whether it's resistant or not. Various environmental screening, especially the high touch things, the screen, the ventilator, the railings, all those things you're going to screen again. And once you're going to swab them, and then you're going to find a data like this, that there is, if you look at the orange one is the positive screening results, and the black gray one is the negative screening results. And you can see that there is a significant neuro ICU exposure as compared to it. And you then were able to show a statistically significant thing, is that the axillary temperature monitoring device was the one which was colonized by it. And then you identify that the axillary temperature monitoring device had a peculiar problem, because neuro ICU require continuous temperature monitoring. So they had this device of continuous monitoring which could not be cleaned properly. And that was getting colonized. Patient's axilla was getting colonized. Subsequently, the organism got entry into the patient once the patient got colonized. So this is what has happened. So endogenous colonization of the axilla was noted in all the cases, while none in the control. An environmental condition was restricted to a skin surface temperature probe in the axilla, and then they identified that a single clade of Candida auris was responsible for an outbreak in the neuro ICU secondary to a contaminated axillary surface temperature measuring probe. So that's how you investigate it. And obviously, if you're smart enough to do this, I'm not. That's why this got published in the NEJM, and you communicate your findings and you get yourself a big name. Obviously, we are not capable of doing this. This is from Oxford, and how they do it is the way that this thing. And obviously, the measure step 7 would be to remove the auxiliary temperature probe and come with a new way to, rather than to clean the environment with formalin, you identified the problem and you reveal that Candida auris can persist in the environment for a long time. So environmental measure is not one single quick cleaning, but you really have to look at this in outbreak investigation. So this is what you do when you are such good epidemiologist. You publish it in the NEJM so that people like us can learn, and I can give take credit as if I am presenting my experience with ICU. Thank you very much for your kind attention. Hopefully I could enlighten you on this topic.
Thank you, sir. Thank you, sir, for such an interesting presentation. Next, we'll move on to the next topic by Dr. K. Subbareddy, sir. I'm proud to say he's one of my initial teachers in critical care. So he's going to talk about early rehabilitation in ICU improves outcomes. Over to you, sir. Sir is the head of the department of critical care medicine at Apollo Health City, Jubilee Hills, and right now he's the current ICCM Hyderabad chapter president. And sir is the clinical director for APCO's Rehabilitation Center.
I'm going to swab them as they come in, and I'm going to swab everyone every week, or twice a week or thrice a week, and I'm going to swab the environment, I'm going to swab the blood pressure equipment, I'm going to swab the pulse oximeter, I'm going to swab everything, and I'm going to look at what's going to happen in this situation. So, and I'm going to look at the people who got infected or colonized versus those who stayed in the neuro ICU but never got colonized, and find out what's the difference. And I'm going to go back. So this is going to be a case control study that I'm going to be doing in this situation. So doing a case control study to evaluate the hypothesis. So what I would do is that they would screen an admission to the neuro ICU thrice weekly and on discharge. Screening involves culture of swab specimen from the nose, axilla, groin, tracheostomy and wounds, as well as urine culture. Isolates are going to be isolated using MALDI-TOF and antibiotic susceptibility testing was done on those things to identify whether it's resistant or not. Various environmental screening, especially the high-touch things, the screen, the ventilator, the railings, all those things you're going to screen again. And once you're going to swab them, and then you're going to find a data like this, that there is, if you look at the orange one is the positive screening results, and the black-gray one is the negative screening results. And you can see that there is a significant neuro ICU exposure as compared to it. And you then were able to show a statistically significant thing is that the auxiliary temperature monitoring device was the one which was colonized by it. And then you identify that the auxiliary temperature monitoring device had a peculiar problem because neuro ICU require continuous temperature monitoring. So they had this device of continuous monitoring which could not be cleaned properly. And that was getting colonized. Patient's axilla was getting colonized. Subsequently, the organism got entry into the patient once the patient got colonized. So this is what has happened. So endogenous colonization of the axilla was noted in all the cases, while none in the control. An environmental condition was restricted to a skin surface temperature probe in the axilla, and then they identified that a single clade of Candida auris was responsible for an outbreak in the neuro ICU secondary to a contaminated axillary surface temperature measuring probe. So that's how you investigate it, and obviously if you're smart enough to do this, I'm not. That's why this got published in the NEJM, and you communicate your findings and you get yourself a big name. Obviously, we are not capable of doing this. This is from Oxford, and how they do it is the way that this thing. And obviously the measure step 7 would be to remove the auxiliary temperature probe and come with a new way to, rather than to clean the environment with formalin, you identified the problem and you reveal that Candida auris can persist in the environment for a long time. So environmental measure is not one single quick cleaning, but you really have to look at this in outbreak investigation. So this is what you do when you are such good epidemiologist. You publish it in the NEJM so that people like us can learn, and I can give take credit as if I am presenting my experience with ICU. Thank you very much for your kind attention. Hopefully I could enlighten you on this topic.
Thank you, sir. Thank you, sir, for such an interesting presentation.